Yes.
Oh, sorry, we have to go over. Sorry, we were muted. I'm gonna say some of what I said again. So, because I don't remember exactly what I said, but a couple weeks ago, we had DMH in here to talk about all of the mental health programs recently that have been set up, that this committee had a hand in. And in talking with Amy, I thought it was really important for Vermont Care Partners and the designated agencies to come also in and talk to us, since you all are on the ground implementing these programs. And I had asked Amy to kind of put it in a continuum of care lens. So we could see sometimes in this committee, we see bits and pieces and it's hard to put it all together. So that's the focus. I'm going to turn it over to both of you.
Great. For the record, Amy Johnson, Vermont Care Partners, Director of Government Affairs and Communications.
Hi, everyone. For the record, my name is Eric Paul Ruiz. I'm the new Director of Mental Health and Substance Use Services with Vermont Care Partners.
So we're going to start with kind of a broad overview of the system of care and the continuum, and then we're going to zoom in to the DA and SSA network, and then funnel even further down to some of the programs and services that you've been hearing about from Commissioner Hawes and Deputy Commissioner Crom. So we'll start with hopefully this.
So I joined VCP about a month and a half ago in December. So I'm meeting almost all of you for the first time today. And I just want to say that I'm very excited to be here to share about the work that we're doing, and I'm very grateful.
You know what, Eric, since I forgot that you are new to us here, so we're going to take a moment and do introductions. So
Yes, Art Peterson, State Representative, represent Rutland District 2, live in the town of Clarendon.
Leslie Goldman from Wyndham 3 in the Bells Falls here.
Laurie Cordes, Addison 4, Lincoln, Bristol, Moncton, and Starksville.
Papa McFarland, and I represent Barrytown and a piece of Williamstown.
Lori Houghton's Essex Junction.
Alyssa Black, Northern Essex.
Brian Chino, Burlington, the Old North End and the East District.
Alan Barr, Enosburg, and Montgomery.
Melanie Carpenter, Lone Wild 2, and I live in Hyde Park.
And Bobby Farley Trujillo, Barnett, Reigate, and Waterford.
And Daisy, Representative Rebecca from Winooski. And we do use first names, so I apologize to anyone if we're too informal for you, but it just makes it really easier. So sorry to interrupt you. Go ahead.
No, thank you for the introduction. It's nice to meet all of you. So today we're going to describe Vermont's mental health continuum of care. And we would like to highlight the work that designated agencies and specialized service agencies are doing in collaboration with our many partners across the continuum to support all of the people of Vermont. What you're looking at on the screen is a modified version of the social ecological model, which is based off of psychologist Yuri Bronfenbrenner's ecological systems theory. Our version is designed specifically with Vermont's mental health system of care in focus. And this is a visualization of how an individual and their family relate to and are affected by different levels of society. We can use this model to better understand even how Vermont's current system came to be. So a little bit of background, our agencies were created as part of an effort to bring people out of institutions, to empower them to live fulfilling lives with their families and within their communities. So in the social ecological model, you can see just how expansive a person's social context is. When you remove a person from that context, for example, by putting them into an institution, this is some of what we're taking from them. And we can also see, for example, that the hospital level of care, inpatient, it is a part of that continuum, but it's just that, it's one small part in a very broad and vibrant continuum. So you can see that the individual and family are front and center within a larger context of these various spheres. And the spheres essentially represent the different levels of our social environment. And each level has distinct influences on the individual and their family, especially in terms of their development, their overall mental health, and their well-being in general. So the innermost layer, those immediate relationships, represent the most direct interactions that people have. These are our friends, our peers, our mentors, and we've diverged a little bit from the original model by including the media here. With the ubiquitousness of social media, easy access to news and information, we can start to see how people are more immediately affected by even the media. Then we come to our external resources, and this is home to the designated agencies, specialized service agencies, and all of our partners within the community. And it's important to recognize here that these relationships are all interrelated. So for example, say a spouse has a conflict at work, they come home, that energy is going to affect their family. Say a parent goes back to school and they have a longer commute, they might have less time to spend at home with their family. That affects that entire family unit. And then we come to the big picture. Our systems, our culture, our values, policies, and laws. Stigma, for example, has an effect on all of these different levels of our social environment. We can think of how something like a pandemic influences our culture and changes our workplace culture and has ramifications on the workforce, for example. And then more broadly, we have the setting in time. Here is a representation of how major life events affect us, past movements, and just as we grow over time, how that affects our life course. And even historical and intergenerational trauma can affect us throughout that life course. And thanks to innovations in the field of epigenetics, we're actually learning a lot more about how that happens on the genetic level. But that is a whole other topic for another time.
We'll figure it out. That, I think, that's
Thanks, Aaron.
Can we hear about epigenetics at some point?
Put it on the long list.
Let's hear about that.
Well, generational trauma, it's huge.
So thank you, Eric, for setting the scene, talking about the individuals that we work with and the nest that they're living within. So now we're going to expand out to that external layer to talk about the continuum. So when I met with Representative Houghton before the session and we talked about the continuum of care, the mental health continuum of care, I think people often think of maybe the mental health agencies, the DAs, the SSAs, and we really wanted to highlight that who is doing the work and who is partnering. It's very vast. So you can see on this slide that there are many partners that are part of this mental health continuum of care. You can see housing organizations, peer organizations, primary care, state agencies. So the DAs and the SSAs are providing mental health supports and services to individuals, to families. And there's many other folks that are a part of that continuum. And we work in collaboration with those other folks, ideally not in silos. So we're going to talk about the work that we do, but I think it's really important. We think it's really important that we're highlighting that it's not just us. There are many other folks involved. So here's us. This is Vermont Care Partners, the designated and specialized service agencies. So you can see a map of where everybody's located. I'm not going to go into too much detail here, but this just really highlights that there are 16 of us. We support the full state of Vermont, and that we all have various catchment areas that we support. And you chime in if I'm missing it. So I just want to level set because I think it's really important. There's a lot of, there's a lot of knowledge about the DA and SSA system. Some people have smaller knowledge and just wanting to make sure that everybody understands who we are and what we do. So we were created by statute. We're in state statute. We're responsible for ensuring needed services are available through program and service delivery, local planning, service coordination. We're monitoring outcomes, and there are geographic areas that the DAs and SSAs support. Or the DAs have specific catchment areas. The specialized service agencies operate in more than one geographic area. And there are 7 SSAs, 5 of which live within the Vermont Care Partners Network. Grounded in the philosophy that everyone benefits when people receive community-based rather than institutional care. Eric so beautifully demonstrated that in the initial slide on why that is important. And a hallmark of our model is coordinated care in the community and integrated at the system, program, individual, and family level. So this might be something more familiar to folks in the room. So this is just kind of overarching what the DAs and SSAs are supporting. In each of these categories, there's a vast amount of work happening, a vast amount of programs. So we have children's mental health services. Folks might be familiar with Success Beyond 6, home and community-based services. There's crisis supports for children. It's very vast. Adult mental health, emergency services, intellectual and developmental disabilities, substance use disorders, and community outreach and education. So again, these are broad overarching categories where you'll see lots of work happening in each of these categories. So we'll move over to some statistics.
Questions? Go ahead. Art.
And this is a fundamental question. If you go back probably one slide, difference between a designated agency and a specialized service agency is in terms of what they cover, what they do. Can you kind of describe that? Because I've always been confused. There's so many agencies that I get mixed up and just want to know what the differences are.
Sure. I'm not so I will also disclose that Eric's been at the agency for 1 month. I've been at the agency for 2.
You don't know it all yet?
And I don't know what, I feel like I have a good answer for this, but there's a lot of people in the room that
I'm sure.
know I'm gonna biff it. So I might boot it over just to Simone to eloquently speak to that for me.
Happy to do so for Director Simone Schmeier, Executive Director of Vermont Care Partners. It is confusing. We often assume DAs are mental health and substance use and developmental disabilities, and SSAs are developmental disabilities only. The reality is there are 7 SSAs in Vermont and 6 are incorrect. 5 are developmental disability agencies. 1 NFI is an agency for youth mental health, youth and family mental health. And then Pathways Vermont is another SSA. And then on the DA side, there's 1 DA that is developmental disabilities primarily. And the rest are more comprehensive in terms of mental health, substance use, and or developmental disabilities. So it is confusing. And we actually have a slide we can send to all of you that outlines it, says what each one does.
I just wonder why they're divided DA and special, and that's what I say. I wonder what the division, if I was to form an agency, what would characterize it as what? Because I've heard this for 4 years now.
Right, and so designated agencies are meant to have touch of one region of the state that they are responsible for. And they are a no reject agencies.
Okay.
So who they can serve, and then specialized service agencies. They can exist, say, in Randolph, but they can provide services.
Right, okay, well, that's a good description right there. So designated in an area versus specialized, which can go anywhere. Thank you.
So I'm going to ask everyone to write down their questions so we can move a little bit.
Right.
No, that was a good clarifying, but then we had like 4 hands pop up. But we got a lot to get through, so write down your questions and we'll get the time.
All right. So everyone's favorite numbers and data.
Yeah.
That's a really good question, though. I wanted to highlight our first bullet point. In the disability services world, our network agency served over 4,600 Vermonters. 46% of those had a co-occurring mental health diagnosis. So the funding might be different when we're talking about disability services and other things, but these things affect all of us. And we're talking about a lot of the times about the same people. 590 of those folks lived independently. Over 1,500 received support in shared staff or group settings. 40% of those receiving services were employed, which really, I think, highlights how untrue the stigma towards this population can be, that they can't work and aren't able to contribute. They can and do and want to be contributing members of society. And then over 2,200 received support enriching local communities by joining events out in their community with friends and family. And I think this just really highlights, it's a benefit to those folks for them to be able to be living in their community. And it's a benefit to all of us as well, because they attend our events and we get to know them. And then in the mental health and substance use world, our agency served over 36,200 Vermonters. We operated 83% of mental health residential beds and 96% of crisis beds. We provided 24/7, 365 days a year mental health crisis response, which served over 13,300 Vermonters. And we served over 13,200 children and families in need of mental health services.
Is this in 23? I'm just wondering.
FY23.
Thank you.
We have some more data and numbers. This represents agency turnover and vacancy data. So the orange line on top represents the turnover rate. Our overall vacancy rate is beneath that in the blue line, and the gray line indicates increases in funding over each fiscal year. And we can see that along with those increases and programs like tuition reimbursement and loan repayment, we have seemed to have turned the corner in terms of vacancy and turnover. Speaking of the workforce issues. And these are our systems-wide vacancy rates separated by DS and mental health, and suggest the same thing, that between 22 and 23, we have turned the corner.
And we know that in one of the committee meetings, folks had asked for, the commissioner and deputy commissioner for DMH talked about our vacancy data. And we know that folks wanted it broken out more specifically. And so if there are questions on this later, we can answer questions.
I love the slide before this one that shows it connected to the increases. That's very helpful.
Yeah, yep. So here is what I'm really excited to talk about. I think that there is a lot of misunderstanding at times about what the designated mental health agencies and specialized service agencies do and where the continuum starts for the work that we do. And so we really wanted to represent this continuum and be able to show you where our work starts and kind of the broad spectrum of where it goes. So you can see that we have promotion and prevention, and a lot of times folks think that that starts at outpatient, children's or adults outpatient, but really we're doing these universal strategies that promote health, wellness, getting really upstream to support folks before they get into a more crisis end of the continuum. So you'll see a variety of programs, and obviously this is not an exhaustive list because there are 16 agencies and there's a lot that we do. But you can see that we focus on social determinants of health work. We have a lot of wellness-based programs to support people upstream. We're in the homes, we're in the communities. There's often a perception that a lot of the work that we do is in buildings, in the office, sitting in a room on a couch, doing therapy. And we do have in outpatient therapy. However, a lot of our work happens in the community, in schools, in homes, either with an individual or two-gen or multi-gen work. You'll see the next category, early intervention. That's recognizing, acting early. So we're screening, we provide case management, community support, respite, our emergency services. We do a lot of early childhood work too. I think that's another area where sometimes folks picture our system of care focusing on kind of older youth or adults. And we do a lot of early childhood programming One of our mental health agencies is also a parent-child center. So that's pretty unique to our system of care as well. And you'll see some of our urgent care mobile crisis 988s. Those are some of the programs that we're going to drill down into with the parade of wonderful folks that we brought along with us. You'll see treatment where a lot of evidence-based modalities that we focus on. We have assessment teams that go out and will do assessments to identify what the root issue is for that individual or what's going on for that family. Service planning and coordination is huge, and I can't talk about this enough, that we are really working with, if we're working with an individual, who else is part of their care team, and we're working with them, communicating with them, and working in collaboration to ensure that the individuals moving through their plan of care and feeling supported, and that everybody who's part of that system understands what's going on and work together. Crisis stabilization, residential. And so that's some of the stuff. I think the treatment box is where people put us often, and that's what people think, but really important to show all of that stuff that's happening before we get to treatment. And then we have our recovery section as well. I won't read down the list, even though I see words and I want to read them. So, so my former boss said to me, Amy, you love a good iceberg. And I do. I mean, if they're melting or the Titanic is involved, yeah, those are the icebergs I'm not fond of. But I really want to, this is my favorite, one of my favorite slides in this presentation, because it just is so rooted in what people see and perceive of the DA and the SSA. So this, what you can see, the iceberg part that's above the water is folks think of DA, SSA might like specific news stories, law enforcement interaction, crises, emergency services. That's all the stuff that when people hear DA, SSA, often that's kind of where they go. What's really, and that stuff does exist, right? That is there. It's part of the iceberg. But then there's this deep pool of work happening underneath the water. And you can see, and again, this is a non-exhaustive list of prevention work that we are doing every day with individuals, families, elderly individuals, individuals with disabilities. Some of the things, and again, inclined to read words on the slide, but I'll let you read them. But I think that there are a lot of initiatives and work that's happening that folks don't often think about when we think about DAs and SSAs. So for example, 6 of our DAs and SSAs are working in perinatal programming, so supporting families in pregnancy, postpartum. We have 2 programs that have doulas that go in and home visit with families and support them to build that parent-child bonding and attachment, which supports child development, it supports child health, and it supports the health of that caregiver and the family. So that's one example of preventative work. We have really amazing summer camps for children that have mental health barriers and developmental disabilities that allow kids to just be kids. Several of our DAs are involved in children's integrated services work, doing early childhood and family mental health. I think there's more things that I want to say here, but these are just a few examples of where we are doing upstream preventative work that is often not thought about when we think about the DAs and SSAs, or kind of overlooked. And so we really wanted to highlight, here's what you might think, but here's what's really going on beneath the surface, that each of the 16 agencies is doing that full spectrum of the work. What have I forgotten?
I think you did a great job. And, you know, in a nutshell, the bulk of the work is in promotion and
Yes.
prevention. And a lot of what our folks on the ground are doing is just that. We are working with folks so that they can be well and happy and healthy. And they don't get to the point where we start seeing things happening in the news where they don't have to go to the emergency department. So it's not something that we see as much, but it's the part of our work that we want to highlight.
Right. And I think the other thing is the programs that we're going to talk about today are some of the ones that we know that this group wanted more information on. However, there are many more that are further upstream that we would love to be able to come in and talk about as well. So we also wanted this slide to kind of tee up, yes, you're going to hear these wonderful programs and how they're going. And please remember that there are other upstream services and supports that we are doing beyond the ones that we'll highlight today.
So are we starting the programs and supports? Because if we are, I want to stop and let people ask some questions. Is this good timing?
Yes.
Okay. So I know Daisy had a question and Brian had a question. And I think Leslie. So Daisy, you're good. Okay, Daisy.
Just quickly, I wanted to note one, fabulous slides. Two, I'm also interested in sort of the internal iceberg. So a lot of kind of what you've highlighted so far is the external facing services that you offer, but I'm also interested in what internally you do, for example, to support the staff at DAs and the operational improvements and things like that. So when you're talking about prevention, you noted that turnover has kind of stabilized. What are we doing to prevent or to sustain that stabilization? What are we doing internally? So what's below the iceberg that we're doing to support the basic needs of staff? What are we doing to make sure that there's a good culture within the DAs, that they feel supported? What are we doing to build, leadership skills among the mid-level managers, et cetera?
I love that question so much. And I know that there's a lot of representation in the room, and I will add some things. And then if that we have a lot of executive.
Yeah, you might get to it. I just wanted to know that is something.
Yeah.
For.
Yeah. And I can answer some of that, or we can come back in and present that, because there's a lot going on with that. I would say, obviously any increases that we can offer staff, one of the biggest reasons why people leave the system is because of wages. People need to be able to meet their basic needs and able to pay for housing. And so when we're able to offer, good benefits, good pay, that's one thing. But we also, for example, at NCSS, and I should have said this, I worked at NCSS for 7 years before taking this role. So not to only focus on NCSS, but when I was there, we started an employee leadership group. And that group of individuals worked to bring any issues that were happening in different parts of the agency to this upper management group, and then work through, we're hearing this on the ground. This is an issue. We're tearing up our cars by all this home visiting. Could we all get, a AAA membership? And so a lot of the ideas that got brought to that employee leadership committee, we were able to figure out ways to shift practices or infuse additional benefits into staff's pockets so that they could feel more supported in the work. We also, one of the things we did was, there aren't a ton of upper management positions at the agency. And so how can people on a team see themselves move within that team? So we started to create a tiered structure. So you might be a developmental educator level 1, and then we created additional levels, which were then also connected to predictable increases. And that was huge for staff because they were able to say like, hey, like I've been here this many years and now I'm a senior developmental educator. So again, there's lots of people in the room, but there are many ways that we're trying to support staff, because it's so important to have high quality staff and to retain them, because those relationships that they build with their clients is critical to their movement on their plans of care and reaching their goals. I don't know if anybody.
I think what we'll do is, if you want to, when you're up testifying, if you want to touch on it, that would be great. Brian?
Yeah, on that note, maybe it might be a better question for the executive directors or some of the seasoned, like veteran, workers,
people.
yeah, like Mary, for example, like not to like single you out, but like I know you've been around a long time. That the DA, that in a good way, the DA. But that my understanding that is the reason the designated agency system is structured the way that it is, goes back to the Community Mental Health Act of 1963. And perhaps someone could talk about like that legislation and how it like led to the existing, because like some of these features like catchment areas and what services have to be provided I think they're rooted in that original federal law. So maybe others could speak to that to help the committee understand what, because I think it goes back to, I think, Art's question, like, why is it this way or why are they organized like this? That when we understand the history, it makes sense. And it all goes back to deinstitutionalization.
Right.
And I think it also goes to Vermont Care Partners being a member organization, right? I come from the mental health membership world. And so I'm thinking of you as in, maybe it's not the way that you function, but, you know, as a policy advocate for the DAs and SSAs, you know, what sort of leadership do you offer the DAs and SSAs? And this is a rhetorical question in terms of, you know, that kind of guidance. And I know with the CCDHCs, Christy will maybe speak to that in terms of, you know, operational improvements that can help further stabilize the system. And
yeah, and I would just like to add, you know, overall, especially in our mental health work, we place a lot of importance on the idea of boundaries. And there's often this distinction between clients and staff and just members of the community. But really, we're all just people. And so the same things that promote good mental health for our clients promote good mental health for our staff. So we have basic needs on the slide, making sure that our staff can meet their basic needs, but also providing resilience training so our staff can cope with the stress of working in the mental health field, which is real. Burnout and empathy fatigue are real. We have mindfulness programming on this slide, and there's a lot of really cool, innovative ways to help folks practice mindfulness. Virtual reality has a lot of cool apps coming out where you can sit and actually have a guided meditation in your own home. So there's a lot of work to be done there. Yeah.
Great, let's keep going.
Okay, so we're gonna swap seats. And Bailey.
Welcome.
For the record, my name is Kelsey Stavseth, and I'm the Executive Director at Northeast Kingdom Human Services.
For the record, I'm Bailey Olden, and I'm the embedded mental health crisis specialist in the St. Johnsbury Parish. Great.
So just before I jump in, I'm going to be talking about the crisis continuum, and then we're specifically talking about the Vermont State Police Mental Health embedded program.
Great, thank you.
So I love your question about the leadership and internal work, and I think we're here to support our community, and that looks like how do we involve stakeholders? I think doing that with employees makes sense, and I know a number of organizations, and again, going back to Mary, who's been here for a while, but staff advisory boards do a culture and climate survey every single year, where we survey as many staff as possible. Pay is the number one reason people leave, but also stress and burnout from the intensity of the work. And so how can we develop internal support and leadership opportunities for people's voice to be heard to change how we do the work? So I just really appreciated that question. So this is a graphic that is borrowed from the Missouri crisis model, but I think it is a nice visual of a lot of the work that's been done over the last few years, but many years in general, and speaks to the home and community-based work and keeping folks who need supports in their community, which is actually one of the best supports you can have, is if you can stay in your community during a crisis, after a crisis, where your natural supports are. That is a powerful way to move through any challenges that come up. And so I have a brief thing that I'll read. But the importance of a well-funded and well-supported crisis system based around social services with expertise in mental health, substance use, and intellectual and developmental disability services is vital to Vermonters and is a needed and essential step towards providing support at the right time and place. Having these services alleviates stress and creates capacity for key partners like law enforcement, first responders, and our hospitals. By having strong community-based services, we are able to respond in a therapeutic best practice way, allowing for interventions that are least restrictive and less costly. The crisis continuum is in active implementation throughout Vermont by the Vermont Care Partners designated and specialized care agencies, and is focused on providing upstream interventions that de-escalate situations, keeping people in their homes and communities, is a vital public safety initiative that provides expertise during challenging situations, provides access and quick connections to trained specialists 24/7 through 988 and local emergency services teams, mobile crisis, which we'll be hearing more about in detail, creates alternatives to hospital departments through urgent care initiatives. And so part of what has been developed and what is evolving is how do people get access to mental health and substance use services and providing alternatives. So the original way, crisis, done a really great job, call 911. You know who you're going to get, someone's going to come right away. And what we found is that because that's been the only entry point for a while for crisis, that places like law enforcement hospitals have been overwhelmed. And so the blue lines that you can see up there are traditional avenues to enter into crisis supports, and more by default than by plan, I think, with the intensity and acuity that's been growing in mental health and substance. The green lines represent alternatives, what has been developed and what is being developed actively to alleviate some of the pressures on law enforcement, first responders, hospitals, so they could focus on their scope of work and let us handle situations that require expertise in these fields. And so 988 has call, text, and chat. NKHS and NCSS have call centers that are cover Vermont 24/7. We also have our local emergency services teams that have developed relationships locally, which is essential to partners in the area, and having those local people that you know who can support during challenging times. Mobile crisis, we're going to hear a little bit more about that, but that is about going out into the community. And then our, what we call is front porch for our specific area, NKHS, which will be standing up shortly. But there are other urgent care models and crisis stabilization programs that allow people to come in and get that therapeutic best practice support, which is currently, and sometimes when there's overflow, being supported by hospitals. We're feeling overwhelmed by that support. And so I think this nicely visualizes exactly what we're trying to do is create those alternatives that have better results and also keep people in their communities. And a couple of things I just want to highlight that kind of emphasize on a more specific level, saying, you know, when we're implementing this, we're not doing this in a vacuum. We're doing it with partners, law enforcement, hospital, primary care, schools. But NKHS is working with local hospitals to develop specific workflows for emergency department staff. So if someone comes in, who do you call? Who's responsible for what? So clearly outlining specific roles and responsibilities. We're developing workflows and protocols with local schools for deployment of supports and services when and if they're needed. And that's related to mobile emergency services. We're working with local municipalities and law enforcement. We're going to talk specifically about the Vermont State Police, but we're also working with local PDs to saying, how do we respond? We've got technology, iPads, so we can do a virtual connection, especially that's important in the rural areas like Northeast Kingdom, where it could take us a while. We only have a few people, but we can be immediately available while we're sending someone to have physical in-person presence. And coming back to inviting participation engagement with communities, we've worked actively with places like Hardwick. We've done joint recruitment on staff. Going back to what Amy was talking about, the relationship people have with their communities and people is so essential. And so if we can work with towns to hire people that they know that they want to work with, that's been a nice plus through collaborations. And we're also working with Newport and St. Johnsbury too, with local law enforcement to embed people when we have time to respond together. And then the last part that goes into this, we talk a lot about services. We give a lot of that kind of background in below the water iceberg trainings. So assist, mental health, first aid. We license a lot of clinicians in the community. That is one benefit that the designated and specialized agencies, we do a lot of training of the next generation of clinicians and staff that sometimes we leave, which is painful, but we appreciate the capacity building. But that's an important part of this crisis continuum.
So I think if we can,
Oh.
before we switch, Art had a question?
Yes, I had a question on the 988 number and its function, and this is wrapped around some testimony we took at the state building, at Asa Bloomfield building in Rockland, in which an individual, which is horrendous to even think about, the building, a 4-story building with a jump to the death inside the building. I'm wondering if the 988 number can be called by another person, or does it have to be the person in distress?
It can be called by anybody,
Anybody.
including people supporting people in distress. So we want to be really clear about that. That's
Okay.
always open to it. And after this, we're going to dive into 988 more specifically, and so we
okay.
can answer that a little more.
Wonderful.
That's a
Thank
great
you.
question.
Yeah.
Thank you. Thank you.
Okay, great. So this is the overview of the embedded mental health crisis specialists in the Vermont State Police Barracks. And so this is statewide. And this is a priority for the governor. And we've also had great success over the last few years with this partnership.
I'm also going to say that although we haven't gone through the budget, if it's a priority for the governor, it is probably in the budget request. So this is really helpful for us to listen to. Thank you.
And so I'll let you read this, but I'm going to speak to the kind of NKHS positions and then let Bailey really speak to what is it like doing the job. And so we have two, which is unique, but our catchment area is large. And so we have a person in the St. Johnsbury and the Derby Barracks. And again, going back to relationship and tenure, those positions have been there for a while, and that only strengthens the work that they do. Again, going to turnover when you're working with human beings, it's not plug and play. You don't have therapists and then another one shows up and you just carry on. It's a reset. Same thing with these positions. So the longer folks have been here, the better the outcomes. And so overall, we served 61 towns and responded across the 3 counties. There was almost 1,000 people in responses. And jump into the data here. So this shows the number of interventions. This is fiscal year to fiscal year, so 22 and 23. 22 is in orange and 23 is in that green, teal. It shows the age range. The majority of folks that we're responding to are between the ages of 18 and 59, although we do serve the spectrum. And so we're seeing young children and then older adults as well. And then, again, going back, like, what is great is that when someone calls for VSP, law enforcement can go out together. The specialist can go out alone if that's deemed to be safe and appropriate. And so there's a lot of flexibility that happens to that. And then, of course, how do we know people are better off or what's working? That a majority of folks are not brought to the hospital, not serving for medical outcome. They're staying in the home and community, and that's exactly what this program is meant to do. And I think that the embedded program connects nicely with that crisis continuum, mobile crisis, and saying that, you know, law enforcement is a key partner that makes the scene safe so that we can respond to these situations, but that it can draw the law enforcement piece closer to the mobile crisis piece and help to bridge that gap between safety and therapeutic response.
Can I just ask a question on the data? If you may not have it. So would you have data back on the hospital piece that shows if this effort over time has decreased hospitalization? Do you know what I mean? So like we see here that, you know, hospitalization is low compared to home and community support, but did it used to be flipped where going to the hospital was higher?
We don't have that data to demonstrate, like, if this position wasn't here, would they go? It's always hard to demonstrate services not used, but I feel confident saying, like, absolutely, this has diverted people from the hospital. And I think maybe Bailey can
Yes.
speak to that when you go about like, well, the interactions and how Bailey's presence, other presidents, like de-escalate situations so that there isn't a higher level of support needed because of the specialty services. But we're always trying to tether that, and we have seen over time, I think, a decrease in hospitalizations for folks. And I would absolutely say that the designated and specialized service agency has something to do with that, and it's the home and community-based work.
Thank you.
But some of them are always working on that, right? Find that data, so we'll bring it when we can.
My turn?
Yes.
I feel like Kelsey did a good overview of what the job is like. So I'm open to answering any questions because I'm sure you guys have some. But I just wanted to add that not only are we doing like the crisis response when someone's in crisis, but we also do a lot of preventative care. We'll get a lot of calls that come in and the trooper will deal with them and handle the actual situation, but then realize there is a mental health component, and then ask for an outreach. And then we're there and can just outreach on the phone or in person and see what's going on and help the individual connect to the resources that will benefit them the most. So even though we are mental health crisis specialists, we are doing a lot of that preventative care before it gets to the point of crisis. So I think that's really important to highlight.
Can you tell us a typical day?
Yep. So my hours are, I'm very flexible with my hours. I kind of go on what's needed. This week I worked 11 to 9, kind of like that split shift, so that I'm seeing part of day shift, part of night shift, kind of in the mix between the days. I have a desk at the barracks in the troop room, and I sit with my computer and my phone, my tablet. I sign on with my computer, and I have the screen that VSP, like all the troopers have as well. So I can see all the cases that come up. I either get a call from dispatch directly asking for my assistance with a call, and they'll give me kind of the presenting issue of the call. Or I'll get a call from a trooper specifically, or I'll see a case come up and read the case and say, oh, I can help here. Like, I know this resource. Depends on the day and the week of how intense call volumes are. I can go a day with no calls, and then the next day there's 3 back to back to back. There's just one of me in the St. Johnsbury barracks, and there's one in the Derby barracks. St. Johnsbury covers Caledonia County as well as part of Orange County. So even though I am contracted through Northeast Kingdom Human Services, I work with Claire Martin Center as well. Basically, my role is to attempt to de-escalate situations, whether that's over the phone, so police don't have to go and respond. Because there are situations where police are not needed. It can be de-escalated over the phone, or go in person with police. In those situations, usually the police will walk into the situation first, make sure the scene is safe, make sure there's no weapons, kind of read the behavior of the client. And then I'll come in, introduce myself, say, what's going on today? Like, usually it's just a conversation. If somebody doesn't want to talk to me, that's that. I don't force anyone to speak to me. And that's the same with every clinician. But basically my role is just to kind of find what's going on, see if I can have the resources to help the person, or if I can connect them to the right resources to assist the person, whether that's shelter, food. There's so many things, substance abuse treatment. There's a very wide variety of resources that people are looking for that aren't just mental health. We do a lot of hospital diversion by going on scene. A lot of that I see with children, where parents and children in that family system are just overwhelmed and they're both not working together well. So historically, police would just go in. Police, they're not trained when you go to the academy. They have very little training, social skills, that resources in the area, the skill set that I come in with on scene. So historically, police would go in and sometimes having a gentleman or a female in uniform can be very intimidating, especially to a child. So when they just go in and then I come in, it kind of, that presence, sometimes can de-escalate the situation. And sometimes people just need to have a conversation. Sometimes it doesn't need to go to the extent of having to go to the hospital. There are situations where I will suggest hospitalization where we are at that crisis point. But a lot of the situations, they can be de-escalated with just a conversation. And I'll, like, say it's a child and a parent, I'll have a conversation with the child in a separate room. And the trooper will go and take the parent to a different room and just kind of see what's going on. Then together we collaborate, tell each other like what we think's going on. And then a lot of times I come up with a safe child and the parent to keep the child in the home, to keep them going to school, and then to connect them with the right outpatient resources.
Great. One question, follow up. So there's yourself and the person in the Derby. Are they the only two barracks right now that have?
No, so we have, I cannot give you the number.
That's fine, but there's more. Okay,
Yes.
we'll get into that later.
The only two barracks that don't have people right now are the Royalston Barracks and the New Haven Barracks.
Okay,
And that's just our recruiting. So this is meant to be a statewide program.
That's what I thought.
Yeah. So it's not just us. We're speaking
They
to our
can't
experience,
find
but like, yeah, and so we do cover sometimes, but it is statewide.
okay. And my other question is, and I apologize because I don't know what communities use Vermont State Police versus have local police. But if you're covering it, could you cover an area that also has local police and could they call you in that situation as well? Okay.
I've collaborated with St. Johnsbury Police Department a few times. They respond to things differently, but if they do need my help and they see that I'm on, they'll reach out to my sergeant that's on, who will then reach out to me, or I'll see it on the screen and I'll offer to go down, or they'll contact the agency, emergency services, and they'll know that I'm on and request my response.
Okay, so there's collaboration there. Great. Leslie, and then Art.
Westminster Barracks has one for sure. Met her and she's incredible. You mentioned that your salary is contracted through the DA. Is that how that works?
That was very specific when we set it up.
Yeah. I just wanted to be reminded about that. So funding the DA is also funding you.
Yes. Yeah, it was originally, I think when and Mary will help me here probably, but I think when the original proposal came a couple years ago, it was through Vermont State Police and we wanted it through the DAs.
Yeah, that's what I remember. Okay, thank you. Thank you for your work.
I just wondered how many visits are repeat visits to folks? Roughly.
Yeah, so that does happen. However, when those situations happen, it's usually because the client really likes to talk to me or really just needs someone to listen to. Or
Develop
just
the
needs that extra
relationship with them.
support.
Yeah.
Yes, there are certain clients that do tend to go into crisis often. Usually in those situations, I've worked with the TA and their team to try to figure out a long-term plan. Yes, because usually those situations turn from not only mental health and behavioral, but more behavioral. So a team collaboration is really needed there.
And do you feel secure when you do these interactions?
Yes, absolutely.
You do?
Yes.
You feel safe? Yeah.
Specifically the troopers in the St. Johnsbury Barracks. I always feel safe with them. I don't think I've been with one on scene that I didn't know that they were watching every move of
Okay, that's what I want to know.
And I've also learned how to stand correctly, like kind of
Sure.
position.
Sure, yeah, I'll bet.
And I've worked with them long enough
Yeah.
to kind of read each other's body language.
Yeah.
So if they see like my facial expression, I'm very expressive. So they usually know when to step in.
Yeah.
But a lot of times it's me talking, and then if I give them like a certain look, they know to step in and say something, maybe support the conversation, or take action, and
Yeah.
which we prefer not to do, but.
Sure. Thank you.
I was gonna add that, your outfit includes a vest.
Yes, yeah, we do have
Show up,
a-
and so like for safety, and so she's
Oh,
wearing
she
a
has
vest,
a
like,
vest. Yeah,
just like the
okay,
police do,
yeah,
so.
gotcha. Yeah, thank you.
I was just wondering what your training is to be able to do this.
So, I was working with Northeast Kingdom Human Services and Emergency Services beforehand. I have a bachelor's in human services and psychology, and I'm in a master's program for social work with the goal of being licensed. In addition, I have been through a lot of trainings provided by Northeast Kingdom Human Services, and also a little bit from the state through VSP. I've done a few trainings. And I have actually outreach to, I'm not sure if you guys know who Morning Fox is, but yes.
Listen.
He is really good about like getting us the tools and skills that we need to do this job. For example, a month ago, due to low staffing in VSP, I'm having a lot more cases that I'm trying to do over the phone, which I don't have, I'm open to admit, I read a lot of body language. That's what I base my decisions off. So doing de-escalating situations, specifically with suicidal or homicidal statements over the phone, can be really difficult. So I did we have group supervision with Morning Fox and all the other embeddeds around the state. And we discussed doing a training for crisis de-escalation over the phone. And so they're setting that up. So
Great. It's very
yeah,
impressive.
anything
Thank
that
you.
we don't feel that we have for tools, they work really well with us to get.
Thank you very much and for the work that you do. I'm just gonna throw out there, you don't have to answer this now, and this is gonna kind of be for everyone in the room who has something to say about this particular program. We would love to hear whether or not you do support the extension of this, that as it is in the governor's recommend. So we can come back to that, but that will be important for us to know. So go ahead.
So I would so we like to get testimonials, and we know that Vermont State Police isn't represented, but just requote from Sergeant, but saying, this position is tremendously valuable and fills a huge gap that previously existed in public safety. I can't see it not being a permanent part of the future of Vermont law enforcement. Not only does it take us a substantial workload off of troopers not intended to provide that service in the first place, but more importantly, ensures the ever increasing demographic with mental health challenges that we deal with are receiving the appropriate response. So we do work closely, give that feedback, training, and find that partnership to be invaluable. So
Going off of taking off the workload, between Derby and St. Johnsbury Barracks, we had a total of 518 interventions last year. And 230 of those were co-responses where we worked with the troopers, went to scene with the troopers. And 250 of those were handled just by the mental health crisis specialist. So that's taking 250 calls and situations off of the troopers.
Yeah, thank you for that.
Great.
Is that everything on that?
for now.
Okay, for now, exactly. Great, thank you very much.
Staying up here with Tony.
Okay, great.
I don't know if this question's for, or even if you want to go for it, but I'm curious to know their relationship with PMH. But
With Department of Mental Health, whether all DAs have a contract with Department of Mental Health.
Yeah, it's just like contracting. It's just, they contract for specific services.
Yes, yes, and the contracts are available if you.
Yeah, I'd be curious
Through
to
ones,
see
yes.
yeah.
Hi, can you introduce yourself for the record?
Sure. For the record, Tony Stevens. I am the Emergency Services Program Manager at Northwestern Counseling and Support Services in CSL. Thank you for the opportunity to be here. I do want to echo, appreciate Bailey's comments and being here. And we also have very much benefited from the embedded law enforcement position. We were the first agency to be able to successfully do that back in 2016, long before funding was ever available for that. And around the safety question, I've heard the troopers say firsthand how much they value those clinicians, and that is an asset to them. So they go everywhere with that clinician to sort of ensure and protect their own assets, so to speak. But very supportive of the program.
Great.
I just want to take a little bit of time along with Kelsey to talk a bit about 98 in a little more depth and answer any questions that may come up. Just kind of start out as a little bit of sort of the history of how 98 came to be here in Vermont. Really was prior to 2019, there were no calls into 98, or as then was known as the National Suicide Prevention Lifeline. Any calls from Vermont were never answered in Vermont. There was nobody to take those calls. So back in 2019, our agency was able to sort of complete the onboarding process and accreditation process in order to sort of become the first call center. At that time, we were just answering 40 hours a week, which fulfilled a need. And we just kind of put that on the backs of the existing crisis or emergency services team, being like, here, you can just do this too. But it was manageable at the time, given the volume. But clearly the goal was to get 24/7 coverage. And thanks to our partners at NKHS, going through that same pretty arduous process to get onboarded, they came online in June of 2021. And that was a milestone for Vermont, where now 24/7 coverage exists, specifically for phone calls into the 988 hotline. I will note that there's a sort of a immediate backup center called Headrest, which is in Lebanon, New Hampshire. They have always sort of been our first go-to or backup center if for some reason either of our call centers can't get the call. So it's as close to Vermont as it can be. If I jump, is it the arrows?
Yeah.
Okay, forward one. We spent a little bit of time talking about this, of just kind of describing sort of that transition from the National Suicide Prevention Lifeline to 988. Known more so now as 988 Suicide and Crisis Lifeline. A little bit about the why behind it. You know, it really simplifies this for the caller. It is a 3-digit number. So just like 911, it's just that ease of remembering in an emergency how to sort of reach out and get support. And I think to somebody else, representative asked about, could another person call? Absolutely. There's a lot of third-party callers that are calling in. They're concerned. They don't know how to help. They don't know where to turn. And so our role is just as much to support them to then support that person, or even sometimes create a 3-way call to sort of start that intervention. When that shift to the 988 number happened, I think it became a little less about specifically being a suicide hotline, and a little more inclusive of more general mental health and substance use crises. And crisis is a very sort of subjective thing, right? My definition, not the same as each of you. And it really embraces that, and that the crisis is sort of defined by the caller. And it's okay to call for any reason. We're not going to say, why are you calling? But we're going to kind of listen to what's going on, assess for safety, and try to connect somebody with the support, the resources they need. The demand and the increases in the volume has been growing and growing and growing. And so what I like about just this very basic bar graph here is I focused on just the dates of July over different years. So if we look in the very far left at July 2000, there were 57 calls that were answered in Vermont in that month. And that was when it was just my call center for the hours we covered. Fast forward 1 year later, the first full month that NKHS was now on board and we had that 24/7 coverage, call volume goes up to 190, pretty substantial increase. Then we fast forward another year, July of 2022, and we see this explosion. That is when, I think it was July 17th, halfway through that month, that 3-digit 988 number went live across the country. Things blew up and they have stayed blowing up. It wasn't just a peak or a spike, whereas July of 23, it's still higher than that, 655. And then just for comparison, I decided to kind of pull the statewide numbers for just last month, December of 2023, and we were up at 834, so higher than it's ever been, and it's not slowing down. I think there may be some graphics you have in your laptops regarding some more specific data about, you know, call volume broken out by age or gender, things like that, if that's of interest, as well as some of the chat and text demand. And Kelsey and others have mentioned that 988 really started as sort of the phone call, the hotline, but it has expanded to people also accessing it, seeking support via chat, through a keyboard, or texting from their phone. And again, thanks to NKHS, we've been able to kind of hit that 24/7 coverage of chat and text as well as of this summer as a full state. And that continues to grow and grow and grow. You know, and certainly I think that tends to be a demographic, a younger demographic that prefers to not talk on a phone and do it electronically, sort of behind the keyboard. It's a little harder to kind of pull concrete data on that because we don't have the same level of data as we do with the phone calls, but as a state, we are transitioning next week to a new platform that will probably track that better. It's kind of managed by the 90-day code. And then the final piece I'll kind of talk about a little bit here is just the overall idea of how does 90-day fit into this overall system of care that we've been talking about in different parts today. Again, we want this to be easy for the caller, for third-party callers, for direct people seeking support. You don't need to know, I'm in Chittenden County, I'm going to call the local crisis team. First call, that number is 488. Anybody can just dial this number, and we're going to be there to sort of support what's going on and make that linkage as needed to the local crisis team, or hopefully be able to just kind of de-escalate and manage that situation ourselves. It's anywhere, it's anytime, and it's live answer. I think that's one thing that is unique. I think all of our designated agency crisis teams do utilize answering services, at least for some portion of their shifts. So a call goes in and it's a quick message being left, and then a call is placed right back to that person. That's not happening, and nor is it allowed with 90-day. It is live answered 24/7. Calls cannot be forwarded. It's not like I could push it to my cell phone and do this anywhere. They have a lot of restrictions around what is okay and what's not. And I really see 90-day as another option for support. It is definitely not a replacement to the emergency service teams out there. I manage one of those teams myself. I know that we can't do it alone. It certainly does take a village. And so this is one more layer of support, certainly not a replacement. And, I think 90-day already is playing a role in sort of this new statewide enhanced mobile crisis response. We're going to kind of continue to determine how active a role that will be, but that is certainly one of the ways that people can call in and ask for that sort of mobile response. And so that's all literally being developed with each day and each week as we get into this. I will pause there.
Several things I want to just add to that about, Tony touched on this. This isn't a replacement, and the strength of our response and how we're building on that is that it's a continuum and it's all connected. I think sometimes people want to parse it out or say this program, like it doesn't work as well unless it's all working together. The second part of make is how do we support staff? And when we were building the program, I want to emphasize that this was done with public and private dollars, and that what really accelerated the success and ability to respond to this is that when we first started recruiting, I think we were looking at $18 an hour to do that. Nobody. And so with this public, we're starting to push into, low to mid 20s. And once you start to get, there is this threshold where it's saying like, oh, now we've had full staffing for a year. And so I know we're not going to pay our way completely out of this, but it does matter, especially for these really intense, acute services. And that when you get to a certain level, you start to see a difference in recruitment and retention. And so we saw a market difference when we were able to pay, and how it works is that you get, I believe it's a $3 an hour stipend. So after 3 months, you get that paid out. So essentially you get a $3 an hour raise, but that made all the difference in our recruitment and retention. In that the fact that this is 24/7, got really creative about part-time when people work overnight. I think there are some technologies coming online where we do have call centers, but for those high volume hours, we can have shorter periods of time, and there may be an option to bring a phone home and be able to respond that way. So as Tony noted, like the volume is increasing, and we're trying to use the data, which is really great from Vibrant, to determine where we need to add other people so that we can answer all the calls that come through essentially.
It's great. It really is an amazing service. We have a couple questions, Alyssa and then Daisy.
To your point that you were just discussing, so if a call is unable to be answered because everybody's busy, it bounces to national, doesn't it? Or New Hampshire?
First stop is New Hampshire, and Lebanon, New Hampshire is getting almost all of those calls. And then if for some reason they couldn't, it would then go to another national backup center, probably in New York or somewhere fairly close.
So do we know what percentage of calls are being answered in Vermont?
They track us very, very closely, entire funding. Whereas that, yes, they said a 90% benchmark is the target, which is incredibly hard to maintain without having multiple staff just waiting by multiple phones at once, because as luck would have it, we have a clinician on the phone and another call comes through at that moment that you don't even know. And so it's pushed to the next call center. You sort of find that out a month later when you get the report saying, oh, you missed a call. I don't have the exact numbers in front of me, but between these two call centers, we are basically running right around high 80s percentage of utilization or answer rates right now.
We haven't seen the budget yet. but I do remember last year it was funded, 988 was funded at the level that it had been in the first year of implementation. And I asked, is that gonna be enough? Is what's in the budget this year enough? Or are you gonna need more?
I don't know what the budget is, but I know, to your point, it had been sort of bare bones staffed based on funding, as if one call would ever come in at once. So it's one employee covering for those hours at my call center, and likewise with NKHS. And that's not sustainable. We now are double staffing every single hour for phones and needing to also have somebody separate for chat and text. And I think we need to continue to increase that as the acuity and the volume goes up in order to kind of keep coming close to those marks.
And I
You need
mentioned,
to be thinking about retention, possible new, when we're looking at the budget.
yeah, in that private philanthropy has gone down every year, and it's their last year that we've entered into that too with our funders there. So that does, for next year need to be backfilled, but we're entering that last year, which is allowed for flexibility, innovation, those things to keep up with the demand, the volume, and some of the technology costs.
I'm sorry.
No, would you be able to, at some point in the near future, come back to us with what you would need to fund this appropriately? Dollar amount specifically, and then what that would mean? Does it mean, steady Eddie? Does it mean adding staff? If you could provide a proposal, that would be great. Thank you.
And just one more question. This is more out of curiosity. You may not be able to answer it. I've been curious now that this has been going for a couple of years here, a year and a half, I think. What is the correlation between pathways, their warm line, is it called? Or do you intersect at all? Do you?
I think Pathways peer support or Warmline is another level of support out there. I will be honest, I don't know enough about it. I believe it is 24/7 now. There's been times where it had limited hours, but I think they're 24/7 now. Sometimes there may be a callback that's needed. There's a message left, and then people are waiting for a callback. I know that doesn't or can't happen with 988. I think there may be some different levels of training there. I know that it's a pretty rigid training program that all 988 call centers have to have in place, as well as policy procedures, et cetera. So I'm sure they have training programs, and I'm not trying to negate that in any way, but I'm sure it's different than the one Vibrant makes us do. We do have a lot of callers that are utilizing both. They're calling our local crisis team, they're calling 988. They're calling the peer support line. They're kind of using all those different resources in the state. And depending on the content of the call, one hotline might not necessarily be equipped. It might be more of a imminent suicidal crisis where they're needing to call 911 or a local crisis team to sort of help intervene, or a mobile crisis team.
Great, thank you. And thank you for the work you're doing.
Daisy, did you have a question?
I was to ask my budget question, but I will take the time to say thank you, Tony, for all that you've done. I know the implementation of 988 and the transition to this and the transition to getting us to being almost 100% in state with our call response is significant. And I know you are a huge part of that in NCSS. And so thank you so much for working so diligently with.
We can only do this much, and we need our partners to engage.
But to have that knowledge, it for the transition and working with Vibrant, which was a really rigorous process, I know was tremendous, and we wouldn't have been able to do it without your expertise. So thank you.
Thank you. No problem.
Leslie?
Thank you. Yes. I'm wondering what happens, do you keep data on the outcome of your calls? What happens, next? So you had 834 in December, and it's halfway there.
We try to track number of referrals we might make, or kind of places we're trying to steer people to. I know one data point that's pretty closely tracked is how often are we able to de-escalate that call? And not all calls need to be de-escalated. Sometimes people are just calling to kind of connect or check in for something. But I think historically, as we've sort of done this, it's been between 97 and 98% of all the calls have not resulted in the need for a higher level of care. Meaning we did not have to utilize law enforcement or 911 to sort of what we would call an active rescue. But to me, that's a huge mark of success, of sort of being able to meet people where they're at meet that need, even if they call back the next day or again that night, we're still meeting a need and preventing sort of that escalation to 911 or emergency department or thinking about an inpatient psychiatric placement.
So
I
do
can
you,
give you a little data on that too,
Sure.
which is, so this is for fiscal year 23, but we had almost 3,400 calls. A little over 1,900 calls were considered imminent risk, where and of all of those calls, we had 57 active rescues and 22 were voluntary. So it's, to Tony's point, it's very small, and a majority, almost all, are resolved on the phone, which is really great.
you then refer them to DAs, or do you have that also as well as?
Yep, I mean, I see us at 988 centers as just one more link, and so if somebody's calling, you know, from Pittman County, we're sort of checking in to see if they're aware of the Howard Center or their, you know, emergency service team. And maybe they are, maybe they're not, but there's also a host of private providers, and, you know, we can try to point them in different directions.
Yeah, that's correct.
And we're linked into 211 and have access to all those resources as well. And Tony had mentioned this before, but an active conversation about how does this fit in with mobile crisis and things like that. So again, coming back, continuing how it all works together, I think that is being actively discussed.
That's great, thank you.
Great, thank you very much.
Thank you.
You got the nicest chairs. Yeah, I like both. Right. For the record, Simone Rischmeyer, Executive Director of Vermont Care Partners.
For the record, Tammy Miller, Director of Access Hub of Washington County Mental Health.
Great. Thank you. And just to, before a couple of things were mentioned about Vermont Care Partners and the role, as Daisy, I think you asked about that. Just super briefly, Vermont Care Partners is an umbrella name, and there are two nonprofits underneath: the Vermont Council of Developmental and Mental Health Services and Vermont Care Network. So we have the policy advocacy arm, and we have the business and innovation arm, where we focus a lot on data, quality, and writing grants, best practice, et cetera. And we have over 20 monthly groups. I don't even, the number keeps rising depending on what we're talking about, but where all the agency CFOs get together on a monthly basis, sometimes weekly, all children's directors, adult outpatient crisis directors. And so we share in best practice, we share in challenges. We have folks from the state come in and talk to us about new policy and hear about implications potentially of those new policies, et cetera. So I just wanted to give you, happy to talk more about that, but wanted to give you a bit of background there. We've been talking a lot today about different access points, and to keep people out of emergency departments and finding ways where they can de-escalate and find safe spaces where they can work together with their families and support systems. And I know you've heard from Department of Mental Health about a number of psychiatric and urgent care models. And that we wanted to have Tammy come and talk about the access model at Washington County. I just wanted to say that we have, since 2019, when PUC started, Psychiatric Urgent Care for Kids at UCS, we now have a number of different innovative models. They've all been funded through one-time dollars, grants, contracts. We had some congressionally directed funding from Senator Sanders, which is wonderful. The Vermont Community Foundation invested in a lot of the planning and business development for these models. And so we now have two other PUC-like models, one at Lamoille and one at HCRS. We have 3 intensive outpatient programs for kids, UCS, CSAC, and Howard Center. And then we have 3 living room models, the Access Hub at Washington County, CSAC has Interlude, and Northeast Kingdom is about to have Front Porch. So we're really trying to expand these urgent care models and to provide those alternate access points, hoping to reduce the level of associated adverse experiences that folks have when they go to an emergency department or are interfacing with law enforcement, and to decrease acuity upon discharge. One thing I'm really excited about, I do not have the data right now, but because we just started this work, but we have 5 of the programs, and hopefully we'll have all of them, working together with VAS. So what we're doing is we're extracting, VCP is extracting data from agency electronic health records, bringing it into our repository. And then, as we like to say, throwing it over the fence to VAS, where they'll do patient matching so they can see the impact of these programs on ED utilization. That's just starting. We've wanted to do this for a while, so very excited about that.
Yeah, I'm glad you brought that up, because I was gonna say, for us to be able to advocate for more funding to move these into, you know, if they work, we need that. We're gonna need that data. So I'm super excited you're working with us.
Yeah, it's been great. Great. So I'm going to turn it over to you. Oh, no, so these, I just started, I threw all this in, but you can read it if you want to know
So these
more.
are the other.
These are all the ones I just mentioned.
Yep.
A little bit of detail. We have a lot more, but.
Okay.
Okay, so the Access Hub of Washington County Mental Health is a living room model. It provides home and community-based mental health urgent care services to guests. So what that means is that we have folks available to go out into the community to meet people where they're at, if they're in pre-crisis or a crisis situation, or they can come to our 34 Berry Street location to receive immediate services for mental health care. Our primary goal is to provide services to guests in the least restrictive environment while reducing the volume of presentation at the emergency department. So it's an alternative to the hospital. As other people have spoke, the hospital can be a really sterile environment where folks aren't getting that personalized one-to-one client-facing support. With this model, they certainly do. We have this wonderful group of peer counselors who have lived experience, not just in mental health, but also substance use recovery. So they really do connect well with the individuals who are coming through our doors. The Access Hub is funded through a state of Vermont grant through DMH. Our constant champion, Mary, had identified this grant and requested that Karen Curley, our director of ICS, or Crisis Services, respond to that grant. And this is how Access Hub came to be. The loveliness of the grant is that we can provide services to folks regardless of their insurance or ability to pay. So there's no cost associated with it. That's a great relief to a lot of folks in our area. So peer counselors are available upon entry to the program and provide genuine, empathic, and supportive environment. So when individuals enter the door, while we do have peer counselors, we also have case management and we have a therapist who is available. Whoever's available greets that individual warmly. We provide them a nice space to sit and have a discussion in. And sometimes all an individual needs is that one-on-one interaction with a peer counselor who also can serve as a kind of system navigator to help folks really determine what services they might need. Slide.
And I apologize if you said that. How long has the Access Hub been open?
3 months, well, a little bit over 3 months. So the first quarter was October 2nd to the end of December. But in 3 months, we've learned a lot about our community.
Yeah.
So we've had 124 instances of care provided. That doesn't mean unique individuals. I want to say it was 68 unique individuals. In all of those instances, with the exception of one, so that is a misprint. So 123 instances were diversions from the hospital. One individual in that 3-month period did need to use emergency room department services, which I think is fairly astounding.
Yeah.
When we opened, that's the right word. When we opened this program, there was the expectation of, we'll see roughly 28 people. That was our goal because that was 70% of the goal determined when this grant was written. And to have 124 instances of care, and 111 of them were of community members who did not have any history or relationship with Washington County Mental Health or other designated entities. We find that quite astounding that we have a community who is in crisis, pre-crisis, they're in pain. So my expectation was to serve primarily our CSP folks who are wrapped in our community support program already. And
Sorry, CSP?
that, I'm sorry, CSP. Oh, community support program. And that's just not the case. We only had 11 interactions with individuals from our CSP program. 25% of our guests were unhoused. Again, I would have anticipated that be a lot higher number. However, if we look at the demographics that we've collected, the majority of folks are gainfully employed. But what they are entering our program for is that they don't want to navigate our system. It's complex. There's a lot of resources out there and they don't quite know how to navigate. And again, our peer counselors have been amazing at helping folks navigate the system to see where they can enter. Other individuals who have come into our services they're fairly acute. They have longstanding mental health challenges along with substance use challenges. And they're more comfortable with a peer counselor and a little bit skeptical of the system. So that's fascinating as well. So 75% of our guests have had the substance use disorder. They've identified themselves as having a current substance use disorder or are recently in recovery. So that first quarter with 124 instances of care. But January, as of today, this number has changed a little bit. We've had 86 instances of care just in January.
Wow.
Yeah, far more than we expected. We're working to increase our hours of operation based on the community need because it's more than quadruple what the expectation was. And we're hoping to have additional hours available. Currently with our structure, we are bare bones and so we only have 1 to 2 individuals on at a time. And that's just not enough to serve all of the folks walking through our doors. So hopefully in the future, if this continues to be funded, which I really hope that it is, this is such a vital program, we will be funded in a way that can have additional employees.
Are you ready for questions or do you? Okay, Melanie and then Leslie and Copper.
Here's when your grant is due to run out.
2025.
Thanks for your great work. This is really exceptional.
Yeah, I'm curious about funding too. So the grant is from where? I missed it.
DMH.
From DMH. So is that something we see in our budget?
Yes.
Okay.
We approved it.
That's what I'm trying to
We approved
understand
it
this.
last year.
Yeah, and I
Yeah,
forgot.
yeah, I know. It's hard to remember all of that. Yeah.
Okay, so that's what we're looking for is a grant in a line item in the DMH budget.
Yes.
Some of the urgent care models are funded in part by DMH budgets and in part by SAMHSA grants, and also private foundations. So it's a compilation in order to make it work.
Of the 75% of the guests that reported current substance use, how many of those, what percentage of those are actually looking for help? And you're actually figuring out a way to help them? Not maybe you, but you're referring to somebody else.
So that's a great question. A lot of folks who identify with substance use disorder who come through our doors, they're not ready for help in the area of recovery. So what they're looking for often is support to talk about it. They're pre-contemplative. They're not quite out of spot where they're ready to give up the substance of choice. I can't give you an exact percentage.
Art?
Yeah, you mentioned accessing the program. How do people come to you?
Oh, I'm
Do
so
they
glad you asked
come
that.
through the door? Do they call, email? I mean, what?
And how do they find out the number?
That's right. How do they find out the number?
These are fantastic questions. Sorry, I'm a nervous speaker. I was gonna do things. So
Doesn't show.
we have so many different referral sources, but primarily folks are coming through our doors self-referral. Before the program went live in October, we had done
Literally coming through your doors,
Oh, yes,
literally walking
just
into the
walking
building.
in.
We were there a couple
We
last
really
year.
wanted to remove any barrier that someone had from accessing support and make it available that support was there immediately. And it's working. Other referral sources are our interagency folks, so screeners, we have adult access, we've had folks referred from developmental services and children's services. Very rarely, but typically those children who are 18 to 23, we will serve anyone over 18. But that's very rare. We haven't had, this is surprising at this point, too many referrals from the emergency department. So while we are reducing the volume of folks who are entering the emergency department, we need to connect with them and make sure they know they also can refer to us.
Yeah.
Anyone else?
So you would also service the emergency department for somebody coming there, Washington County Mental Health, right?
Serve as the emergency
Well,
department. So
It's just go to the emergency department if somebody is
As the DA.
as the
As the
DA.
DA.
So we could potentially, I think at this time, it's primarily our screeners who are meeting people at the emergency department. However, if they were to call Access Hub, we are mobile in that we can go out into the community and we certainly can go to the hospital if someone needs us to meet them there.
So I guess my question is, and I know it's only been a few months, have we seen utilization in the emergency department go down? I mean, I know that you're diverting, but have we actually seen those numbers come down?
I do not have that number. Wish I did.
Be interesting.
Yeah, and that's what you're working on with thoughts, right? Yeah, great. Good. Yeah, Todd?
That's confusing to me now. Because your first two bullets up there are 124 incidents of care provided. All instances of care were diversions from the emergency room.
Yes, when people come in, when we are collecting their demographics, one of the questions we ask them is, if you hadn't come here, where would you have sought help? And the overwhelming answer is the emergency department. So in that sense, you could infer,
But we haven't seen the hospital. This is a great program and thank you for coming to tell us about it.
thank you for having me here to talk about it.
Good. And from the ones
Oh, she is.
I didn't look behind me. You know what, can we, do you need the slides up? Is she part of the testimony?
She is.
And we would rather see her if that's possible.
Amy, do I just stop share on that?
Yeah. We all have it up, so. Great.
Great.
Hi.
Hello. Nice to see everybody.
Good to see you. If you can introduce yourself for the record.
Absolutely. For the record, Ann Bilodeau, Chief Operating Officer for HCRS. HCRS is the lead agency for the new Enhanced Mobile Crisis Initiative that is statewide across Vermont. And I'm here today to share some highlights on this new initiative. So I want to start off by saying and recognizing that we have always had really strong crisis outreach for the community across the state of Vermont. We have always done a great work to keep people, to help people from a resource standpoint, and also to keep people out of the emergency rooms whenever possible. So I just want to start off with some statistics to kind of set the stage for this program. So in 2022, across all designated agencies, we served approximately 30,000 people. In 2023, that number rose to 40,000 people being served across all designated agencies. I guess I don't have to tell all of you that that is a dramatic increase in what we're seeing for crisis situated clients served across the state of Vermont. When we looked at 2022 and we looked at our crisis services, so again, just want to be clear, these are crisis services only. We had 17,000 unique encounters. 9,000 of those were in emergency rooms. So this enhanced mobile crisis program is not just about hospital diversion. It's really about meeting people where they are at and providing, instead of a one-person response, a two-person enhanced mobile crisis response, so that we can have a clinician providing assessment and support, and ideally a peer support worker as well. So it's a wonderful SAMHSA best practice model that we just launched on January 1st, and it is really, really exciting. I'm going to talk in a little bit about some of what we've been seeing since January 1st. Going back to those 17,000 unique encounters, the model that we're hoping for and working towards is to hopefully shift between 50 and 60% of those 17,000 encounters to a two-person, instead of a one-person, a two-person mobile crisis response. So it is really exciting. It hopefully will make a world of difference for our communities and the individuals that we serve. So, so I do want to just mention, it's important that when we talk about hospital diversion, that there is an important place for emergency rooms and hospitals in the world of crisis. And, you know, it's not always needed, but sometimes it is very needed. Sometimes when it's not needed, it also can cause more harm. So at the heart of the enhanced mobile crisis response model, we're really hoping to reduce harm, to meet people where they are at in their community, in their home, wherever they need to be, need their services, and to hopefully de-escalate and provide a more personalized approach with two people, again, a peer support and a clinical person. I also want to point out that the past definition of crisis and the folks that we were able to serve were defined as a mental health crisis and did exclude persons with primary substance use disorders. And now we are able to serve that part of our population. And that is critically important to point out. So overall, we have been doing a great job, very important to realize that and to recognize that. But that this new enhanced mobile crisis model does provide a higher level of crisis support. So if we had the slides up, which we don't, I'm just going to kind of go through a couple of highlights on.
Would you rather have them up? Is it okay? Great.
I think it's perfectly fine. And I know we're going to move to questions soon. Yep. So the two-person team, as I mentioned, is comprised of a mental health professional and a paraprofessional that ideally would be a peer support, somebody with lived experience, but it also could be a case manager, another clinician. It could be a number of people that are involved in the network of our staff that currently provide services, as long as they are trained to go out on a two-person response. So this rapid mobile response is also available to people of all ages. Adults and children. It provides 24/7 intervention. So this is a round-the-clock model. It provides screening and clinical assessments, including lethality. And again, as I mentioned, it's all about stabilization, de-escalation, and safety planning services. It does also provide mental health peer and recovery coach supports, which is something we have not been able to provide before. Provides bilingual services, and also really important, the coordination and referral model to health, social, and other services. And these are staff that are trauma informed and responsive to trauma situations. In addition to all of that, this program also offers follow-up services that we are able to bill for, which is great. And these can be in-person telehealth or in the office. And the follow-up services would be done within 3 days for adults, so that is required, as well as up to 7 days for children and adolescents. So it's really a very strong program. We're really excited about this program. We ran a soft launch starting from November 1st through the end of the year, and then a hard launch, a full launch on January 1st. And I am really pleased to say that every designated agency put great effort into testing and piloting during that soft launch period and had great success. Success varied across the state, of course, because it's a learning process. But we were met with a lot of, we heard great stories about how staff were experiencing going out on a two-person team and how much it meant to the clients and to the person in crisis. Since we have launched January 1st, every designated agency has gone out on a two-person enhanced mobile crisis, some more than others. But the feedback is that, and what we're learning, and I guess, again, it's early, we're 1 month into this, so it will take some time to really get the reporting in and truly understand how the program is working. But we are hearing great stories about how much of a difference it has made in the client's life to have two people, in particular, someone who is there, if it's a peer support situation, to help calm and de-escalate the situation and to take the time. So this program offers us the ability to spend a little bit more time and provide more resources. So I just wanted to share that so far we're seeing some real impact on the communities and the families and children and adults that we do serve. So I will stop there, and I'm happy to answer any questions.
Great, thank you so much. We're running short of time, and I want to make sure we absolutely get to Claire Martin. So I'm going to throw out a question that I'd rather just have you come back and answer. You'll come back for, I'm sure, in a couple weeks. I'd love to understand, knowing that it's just a month in, how have the mobile crisis units that were within various designated agencies been rolled into or impacted by, or, how is that all working through this process? And, want to make sure there's duplication, that there's a path forward to eliminate the duplication. So just some more.
I'll be happy to return. Thank you.
Great. Thank you so much. Anyone else want to throw out some questions, or are we good for now? Okay, great. Thank you so much. I know we had a training slide in here.
I do not need to go through that.
Okay, great. Can we?
But I do need to figure out how to get you to Claire Martin slides. There we go. Well, okay. But yes, I will talk about that another time.
Okay, yeah, we'll have you back for budget conversations.
Hi, how are you? For the record, Christy Everett, I'm the Director of Operations at the Claire Martin Center. Great. Thank you. And I'm really excited to talk about the work that we're doing with the Certified Community Behavioral Health Clinic and development here in the state. I think a little bit just for some history, it was asked earlier about the Community Mental Health Act. So in 1963, President Kennedy signed the Community Mental Health Act. It said that every community needs to establish a community mental health center, but no real definition of what a community mental health center needed to have in it. Through some work, the Excellence in Mental Health Act was passed in 2014 that really established certified community behavioral health clinics. One of the things that did was provide a federal definition of what it means to be a behavioral health center. What are the services that are required to be a part of that? And the CCBHCs were formed from that. 8 states were allowed to join the federal demonstration to become a CCBHC and get funded through an enhanced FMAP. Through then, there's been ongoing work to have other states start to do some of this development, become certified CCBHCs as well. And we have been a part of that here in Vermont. There are 9 required services that every CCBHC needs to provide in their community. Targeted case management services, intensive services for veterans in the community, outpatient mental health and substance use services, primary care screening and interventions, screening, assessment, and diagnosis services, peer supports, and I think I missed 24/7, thank you, 24/7 crisis services. So in order to become a CCBHC, at minimum, that's what you need to be able to provide to your community. As part of the development, this is not something that the state of Vermont has funded, but in 2021, we actually applied for a SAMHSA grant to become the first CCBHC in the state of Vermont. We were successfully awarded a 2-year grant to begin this development and expand our services. Since then, SAMHSA has continued to release grant opportunities for additional clinics to join. And then since 2021, now 4 other designated agencies have received their SAMHSA grants to expand their services. Northeast Kingdom Human Services, Howard Center, Rutland Mental Health, and HCRS. They are all now have been provided funding by the federal government to expand CCBHCs. So there's a lot of work that has gone into this, a lot of work that we are doing, but a lot of benefits that the system can experience through this. We have been able to add 15 staff members to our staffing, and staffing has always been an issue across designated agencies, but Clara Martin Center did not have any peer program at all. Through CCBHCs, we're able to actually develop that and embed that into the work that we do. We were able to add case managers to help with care coordination activities out in the community, working with different providers to bring that on. We've been able to add an advanced practice registered nurse to help with prescribing, because we know that there's an issue with having psychiatry staff available. So we've been able to add those positions. And I think one of the other things that CCBHC has really benefited when we talk about how does this benefit staff that we have and support the work that they're doing, there is a focus on evidence-based practices. So we've been able to support staff to get really intensive training to either be certified in something that they have an interest in. If we have a need in the community, we can provide that intensive training and support to staff to enhance their education, provide these services. One of the other pieces of CCBHC that's been really beneficial is how are we working with our community partners? And some of that is how do our health information systems work together and talk together? So the CCBHC allows for some of that expansion to happen. I think a great example of what we've been able to do with our CCBHC grant is we recently worked with our advisory board, which is made up of folks with their own lived experience. And we discussed with them the option of actually developing on-site blood draws right in our community. And they were really excited about this because they have shared their experience of feeling some of that stigma when they go to a hospital setting, to a medical setting, to need to get blood work done, and they're diagnosing. So we talked to them about bringing this on site, and we were able to develop this, and we were able to work with Quest Diagnostics, who provides the lab work. So we do the blood draws on site. Quest Diagnostics will test the lab work at their facility, and then through our electronic development, we now get immediate results when a lab work is done, instead of waiting to have to seek results, wait for them to be faxed to us. Our psychiatrists, our medical staff now get those immediate results as soon as they're known. So we can follow up on sort of chronic conditions. If there's substance issues or different things like that, we have those results immediately. So it's decreased that wait time for services. It's allowed for an enhanced coordination with our community partners. And I think those are just some of the really key pieces that CCBHC has allowed us to expand. Not even missing is the ability to enhance the rates of pay that we've been able to pay for folks. And I think that's going to benefit both CCBHC and state of Vermont supporting those increases. So it's through that collaboration. We've also been able to decrease our turnover rates, similar to what other people have said, to pre-pandemic levels because of those two options for funding. I did want to share some of the data that we've been seeing. So like I said, we've been doing this since 2021. We've been tracking different things that we've been doing. We've been able to sort of see the makeup of people we're seeing, both by ages as well as their insurance status. So people who are self-pay or underinsured, the amount of folks who have commercial insurance. CCBHC has allowed us to expand services to people who might not have been eligible for them. So folks who have a substance use disorder aren't necessarily able to receive case management services. Now we've been able to provide case management services to folks who have primary substance, or expand our employment supports to folks who might not have met the statewide eligibility for vocational rehab. Through the targeted case management, you really can look at what does the person need, and we can craft services so to meet some of those needs. I did include sort of just our calendar year 2023 expanded services. And we provided over 23,000 expanded services just under CCBHC. And I think in an average year, Clara Martin Center sees about 2,100 unique individuals. For kind of calendar year 23, just under 1,500 people were specifically able to receive CCBHC services. And those are people who would either have received services through the DA, but received an enhanced service through CCBHC, or was someone brand new who we had never seen that we were able to bring into services. So we've seen a pretty remarkable response, both from our community and from our providers wanting to be involved in this work, because it finally gives them some tools to be able to help and support needs. And it's also helping to support needs outside of an office setting. So there's a lot of work that's done in the communities, in people's homes. We have been able to co-locate a children's mental health clinician in our local FQHC. Before, we only had an adult clinician there. So we've been able to expand our workforce and do some of that work. So I think we're just starting in some ways, even though we've been in a few years, just starting to see some of what we can do to enhance our services here. And now beginning to work with the state. The state has received a one-year planning grant. So we're in the process of working with them. Where does the state of Vermont want to go? CCBHC? I'm not sure if you want to hear more about the state.
Yeah, no, I mean, I'm just looking at being mindful of time, but yeah, we're working closely with the state on CCBHC and implementation and planning for that. And also we have all of our agency CFOs really learning and utilizing the CCBHC cost report, which is a federal template to detail current and future costs, which I think will be really helpful for all of you as well. And we have the 5 agencies with the grants coming together to, again, share best practice, and 5 agencies that currently don't have grants are going to be coming together as well to be preparing for CCBHC and thinking about what structures need to shift in their agencies.
So I know Art has a question, but first, so something you said piqued my interest. So are you a CCBHC and a DA still? And how does that work?
Yes, we are a DA. We are funded under SAMHSA to explore CCBHC expansion. So technically, the state needs to certify DA as a CCBHC. They're going through that process.
Okay.
So once they go through that process, they will provide us CCBHC certification.
And so that would then, in theory, the DA would, I mean, not go away, but you would be a CCBHC rather than you'd be a designated agency that's a CCBHC, I guess. I mean, you'd still be a.
It doesn't
You're
go
included.
away.
It doesn't go away. It's just that you're still a designated agency under our system of care, but you're operating as CCBHC, which allows you to do all of these other things.
Exactly. And I think a lot of that is still being determined by the state in terms of the certification criteria and how the funding will work, et cetera. So that's all.
Okay. To be determined.
And you know, and a big piece too, I will just say, of why CCBHCs were started was also to provide parity between community mental health centers and FQHCs in terms of funding and having it be more cost related or cost based. And so we are hopeful that this won't be our, you know, it's not going to solve all problems, but it has the potential to solve some of the.
Because of the enhanced federal funding.
Enhanced federal funding lasts for 4 years, so the enhanced federal funding for sure, but then also the cost reports allow you to look at your actual cost as opposed to your Medicaid rate and what you can fit into that, which is a different approach.
Yep. Art?
Yeah, this wasn't my question. I don't want to keep everybody for lunch.
Yeah, that's okay.
So you're not on the first slide as a DA. The first slide here showed all the DAs and where they were. You're not on, this isn't.
Claire Martin Center?
Yeah.
Claire Martin Center's on there.
It is.
Yes,
It is one.
Yeah, we
Okay.
see.
All right. My real question is, what role does telehealth play in what you do? Or does it?
Well, I think through COVID, you know, the ability to provide telehealth services just exploded. CCBHCs and our role has just continued to evidence that.
Say that again?
That through COVID, our ability to provide
Right, I
services
agree
through
with
telehealth expanded.
Yeah.
CCBHC has just allowed that to even boom even further because it really is going to, where does someone need services? And if they are need to be seen in their home, or we can't get there for whatever reason, we have the capability, we have the technology to be enhanced to provide telehealth.
So you are using it.
Yeah.
Okay.
Yeah, pretty significantly.
Thank you. All right, thank you.
Any other questions? This is really exciting. And we appreciate you being innovative and going out first to apply for the grant and work on it. So I think we're
They've been
wonderful.
so supportive. It's Claire Martin Center has been so supportive of every other agency coming into it, just really providing a lot of guidance and expertise. So we're not recreating every single time.
Yeah, exactly. Great. I'm sure we'll want to hear more eventually, but this has been a great morning. I appreciate everyone coming in. It's always helpful to hear from the people doing the programs, and reach out anytime, provide us information. You don't have to be here to testify, to, send me an email that we can share with the committee on things that you're doing or things that you need or reasons you want to come and talk to us. So